Good evening to everyone. I must thank David Berger and the organizers for having invited me to this exciting session on COVID-19 antiviral pharmacology and therapeutics. These are my potential conflict of interest. And this is the atypical disease we are facing in these times. As we learned in the last 2 years, SARS-CoV-2 infection causes minor injuries to upper airways in most people affected, while only a minority develop a form of interstitial pneumonitis, whose pathophysiology has been described as a cytokine storm with proportional lung damage and respiratory failure. But to understand the biphasic nature of this infectious disease, it took more than a month, while COVID-19 was still only in the Far East, according to the information we could gather about it. The disease was described as viral pneumonia. And an editorial published into The Lancet on February 15, 2020, advised against the use of steroids, showing some example of other known forms of viral pneumonia. We know the story of how steroids were subsequently found to be life-saving in hospitalized patients, and thus confirming that severe COVID-19 was not a typical viral pneumonia, but rather a phenomenon consisting of an initial viral invasion of the respiratory tract, followed by an intense inflammatory immune phase, no longer dependent upon its initial viral trigger, thus implying that any viral measure to be effective should be undertaken in the early phase. In medicine, few are the diseases whose clinical course become independent from the original perpetrator. One is certainly the rheumatic fever, which follows a streptococcal infection. And other examples may be those of autoimmune hepatitis in vulnerable subjects, such as those with familiar story of autoimmune hepatitis, in whom the disease developed following an acute viral infection. Thus, the window of opportunity for any antiviral therapy is the early phase of infection, when viral multiplication and diffusion into the respiratory tree can be inhibited with favorable downstream outcome. And a rationale for this is also provided by the fact that disease severity is proportional to the viral load measured initially in these patients. The first antiviral option made available was remdesivir, a polymerase inhibitor, which is not an orally administrable drug, but its multi-phase development in the treatment of SARS-CoV-2 infection made it possible to better understand the right timing for antiviral use. Remdesivir was first challenged in severely hospitalized patients with no benefit. A second trial in an intermediate disease phase gave conflicting but encouraging results, with also a tendency to lower mortality. The third attempt, made in the very early phase, was eventually fully successful, with a relative risk reduction of hospitalization approaching 90%. Another useful information provided by remdesivir concerns its chemical structure, bearing an oxidral in position 3 like other antivirals, and the same applies also to molnupiravir. Closer similarity between remdesivir, molnupiravir, and the natural nucleotide makes it possible the elusion of the proofreading machinery of SARS-CoV-2, thus avoiding the removal by excision of these drugs bound to the growing chain. Molnupiravir is thus not a real chain terminator, as natural nucleotides can be assembled following molnupiravir binding. However, its incorporation causes what is called error catastrophe, which eventually end up with molecular structure no longer compatible with viral replication. This is the basic pharmacology picture of molnupiravir, with negligible differences between day 1 and 6 in terms of PK profile. The half-life in plasma is short, as with all antiviral polymerase inhibitors, as the driving parameter here is the intracellular concentration of the triphosphate active moiety. Elegant animal studies were made with molnupiravir on ferrets, which have the remarkable property of having the same receptor, ACE2, that SARS-CoV-2 requires to infect human cells. a series of experiments with infected animals, exposed uninfected animals, made it clear that the drug was able to quickly reduce the viral burden and decrease the likelihood of spreading infection from treated animals to uninfected exposed controls. In phase 2-3 studies, molnupiravir was found to reduce both the viral load and the need of hospitalization in a dose proportional manner, as seen here on the right of your slide. This is also apparent from this graphic showing a clear proportionality between the dose of molnupiravir administered and the magnitude of viral decrease, as can be seen here. In the phase 3 registration trial, 716 patients with at least one risk factor within 5 days from symptom onset with no vaccination were compared to 717 placebo recipients. It's worth noting that the proportion of patients older than 60 was quite low in this study. Molnupiravir intake was associated to a relative risk reduction of 30.1%, but with only one death versus 9 in the placebo group. There are also some discrepancies to note, as the higher efficacy in those with more than 3 days since symptom onset versus those with less than 3 days from symptoms onset should be the contrary, and the less than expected efficacy in those older than 60, which is also unexpected. It must be remembered that this trial was begun when monoclonal antibodies were already available and possible inconsistencies in the enrollment of older patients might have taken place. Good news in terms of tolerability and side effects, with no major differences between molnupiravir and the placebo group. A second oral antiviral is, instead of a nucleoside analog inhibitor, is a protease inhibitor. Is an inhibitor of SARS-CoV-2 protein cleavage, which is associated, incorporated with ritonavir. I wouldn't say incorporated, I would say associated in the daily intake. Ritonavir is here used as a booster with increased absorption and delayed clearance of nirmatrelvir, which is the active drug of this association. From a pharmacological viewpoint, we must note a half-life of clearance around 6 hours, which is compatible with full coverage of the dosing interval by active concentration, and no need to reduce the dose in case of estimated glomerular filtration ratio below 60 milliliter per minute. This clinically is important, as most of the patients we treat with this drug are well older than 60, the age of 60. The phase 3 registration trial of nirmatrelvir was a big study with 1,120 patients who received the drug and 1,126 placebo recipients. Criteria were quite similar to the molnupiravir study, but it must be noted that no prior SARS-CoV-2 infection was allowed. So this was an exclusion criteria. To note in the study population is the fact that more than 50% of patients enrolled already had a positive serology, which challenged a bit the rationale of early therapy. Nirmatrelvir was associated to a highly significant reduction in hospitalization. No deaths were recorded in the nirmatrelvir arm, while 12 deaths occurred among placebo recipients. The overall figure is that of relative risk reduction approaching 90%, and a number needed to be treated of 17.45, which is quite small as compared to molnupiravir. As expected, the drug was also associated to a faster decrease in viral load, especially in those with negative serology and in those with the highest viral load at baseline. Diarrhea and dysgeusia were the most common but manageable side effects attributable to the drug. So at the end of the story, we have a hierarchy in the choice of early treatment to provide to patients at risk in the early phase of SARS-CoV-2 infection. You can distinguish a first line choice, which includes remdesivir and nirmatrelvir ritonavir, and also up to, I would say, a month ago, also the monoclonal antibody sotrovimab, which is, however, no longer active against the prevailing variant. This is clearly based on the efficacy rate shown up in the registration trial. The second line consists of only molnupiravir, which is associated to a 30% of relative risk reduction. However, it must be noted that in terms of the secondary endpoint of the death rate, there was a convincing difference favoring the drug. So this is what is available today, and there's a clear debate. There has been a debate about using monoclonal antibodies or antiviral drug. Now there are no choices around, so we must rely upon antiviral drugs, and this is what we can do in our practice. The key factor, corresponding to the title of this lecture, is how to best use this drug. So the best use is a logistic arrangement and organization in order to possibly catch up patients in the very early phase. I would suggest that within 3 days of symptom onset, possibly by also looking at recent at-risk contacts of infected persons. I thank you warmly for your attention.